which do not spare even the younger people, we as gynecologists have to be ready to face a category of cancer survivors who will require hormone replacement therapy. So, this talk or presentation is dedicated to all those strong women who are fighting cancer. You're braver than you believe, and stronger than you seem, and smarter than you think. Menopause is defined as the cessation of menstruation after either natural or surgical loss of ovarian function. Induced menopause is the cessation of menstruation and ovarian function due to surgical removal of the ovaries or damage to the ovaries from radiation or medical treatment. Many a times, induced menopause leads to total and permanent cessation of periods. Sometimes there is recovery of ovarian function after a year or two from premature ovarian insufficiency after treatment for malignancy. Now, what are the symptoms? Symptoms of menopause and the sequelae of gynecologic cancer treatment can be severe in their physical and mental impact on patients' quality of life. And the symptoms are like hot flashes and night sweats, insomnia, sleeping difficulties. They're really troublesome. Osteoporosis, muscle loss, cognition deficits, depression, and of course, genitourinary syndrome of menopause. So here we have, let's assume that we have a case of a 39-year-old Nandini, who is a scientist, and she's at the hem of her career, raring to go higher in life. Suddenly, one day, she's struck by cancer. Post-cancer therapy, she lands up with premature menopause. As a gynecologist, it is our responsibility to give her the best quality of life and treat her appropriately. So suppose this lady, Nandini, has come after endometrial cancer treatment. So what do? Can we give her hormone replacement therapy? Well, what does the ASHRAE guidelines say? HRT is relatively safe in early stage endometrial cancer survivors and may be considered if non-hormonal therapy is not effective. The safety of HRT in advanced endometrial cancer has not been proven and thus not recommended. In case of patients with stages 3 and 4 of endometrial cancer or high-risk endometrial cancer, non-hormonal therapy should be used to control menopause symptoms. So the signal is red. What about if she had ovarian cancer? Well, HRT has a favorable impact on overall survival in patients with epithelial ovarian cancer. There was a significant reduction in ovarian cancer-related deaths among women who received HRT, a study done by Lee et al. And so we give a green signal to HRT in patients post-ovarian cancer therapy. What about HRT in patients with cervical cancer? Squamous cell carcinoma of the cervix is not a hormonally driven cancer, and ovarian conservation is recommended in patients who are premenopausal at time of diagnosis. In those patients who experience induced menopause after cervical cancer treatment, it is safe to use HRT for symptom management. Data is less clear for adenocarcinoma. So combination therapy is recommended for patients with a uterus in situ, like cervical cancer. Also, most vulval and vaginal cancers are HPV-related squamous cell carcinomas and not hormonally driven. So it is reasonable to offer HRT to survivors of all these cancers as well. So the signal is great in breast cancer. Well, HRT is generally not recommended after breast cancer as they are mostly hormone dependent. HRT can increase the risk of recurrence. Hormone replacement therapy in patients after risk-reducing surgery. Now, this is a new indication for HRT, a relatively new indication with more and more genetic testing being done and BRCA1, BRCA2 coming positive. So what are the indications? Currently, patients with BRCA1 mutations are recommended to undergo risk-reducing bilateral salpingo-oophorectomy at about the age of 35 to 40. And all this comes after, as per the guidance of the genetic expert. Patients with an increased genetic risk for gynecological cancer due to BRCA mutation or Lynch syndrome are likely to undergo risk-reducing surgeries, and this in turn induces menopause. And what about patients with BRCA2 mutations? They are recommended to undergo BSO at the age of 40 to 45 when the risk is high for cancers of the uterus. What about and then a short course of estrogen therapy may help alleviate the symptoms of induced menopause without increasing the risk of breast cancer after oophorectomy. The risk of breast cancer is greater, however, if EPT, that is estrogen progesterone therapy, is given versus just simple estrogen therapy. A point to be noted while giving HRT. What about patients with Lynch syndrome? Patients with Lynch syndrome who have undergone prophylactic hysterectomy may use estrogen therapy alone for treatment of menopausal symptoms without increasing the risk of colon cancer. What are the principles of treatment? In patients of iatrogenic premature menopause, that is cessation of menses before the age of 40, HRT is very important in such cases. It is recommended up to the age of 50, in fact, to manage symptoms of estrogen deficiency. Not only that, but to protect bone health, to potentially reduce the risk of cardiovascular disease. And what kind of monitoring do these patients require? They require an annual monitoring of their bone health, cardiovascular health, neurological function, and sexual health. And how do we... So any patient who comes with premature menopause, iatrogenically induced, do we give all of them the menopause hormone therapy or do we select? So the selection criteria is if the patient has a normal weight, normal blood pressure, she's physically active, and her 10-year risk for atherosclerotic cardiovascular disease is less than 5%, and she has a low risk of breast cancer, then she is eligible to take HT. And if she's at an intermediate risk for HT, if she has diabetes, she is a smoker, she has hypertension, she's obese, she leads a sedentary lifestyle, she has an autoimmune disease, and she has hyperlipidemia or metabolic syndrome. What about patients who are high risk? Who are they? Those who have congenital heart disease or who have atherosclerotic cardiovascular disease already, venous thrombosis or pulmonary embolism history, then stroke or TIA or myocardial infarction history, breast cancer. So for these patients, HT should not be prescribed. So what is the estrogen and what is the progesterone which is best suitable for premature menopause? We're going to wait for a long time. So right now, the best estrogen suggested by ESHRE is 17-beta estradiol. This is the preferred estrogen. In fact, its active form is called estradiol hemihydrate. And it is available in oral preparations and transdermal preparations. Transdermal preparations come as gels, sprays, and patches. The dose of estradiol is 2 milligrams orally. In the gel form, there are two sprays which are given of 2.5 grams and which contains 1.5 grams of estradiol. So what about the progesterone? We give a progesterone only when the uterus is intact to neutralize the endometrial hyperplasia, which is caused by estrogen. And which is the progesterone which is used? Micronized progesterone, either 200 or 400 milligrams. Dihydrogesterone, 10 to 20 milligrams. LNG IUD, that is levonorgestrel intrauterine device that we are using so often for other indications like AUB, O, AUBE, etc. 52 micrograms per day is released from the IUD. These progestrogens have better breast and CVS safety and they are less androgenic. That is why these are the progesterones which are preferred. And there are two types of therapy which are given. One is the sequential hormone therapy in which progesterone is added in the last 12 to 14 days. So estrogen we give continuously, say for a whole month, and then in the last 12 to 14 days, progesterone is added. And this is done in every month cycle. In the combined HT, progesterone is given for all 28 days. Some of the examples for brands are Femistone, because Femistone is one brand which is available in all strengths, in many strengths rather. So therefore, the example has been given. So there is a Femistron 2 by 10, which contains 2 milligrams of estradiol continuously, and for 10 days it also contains dihydrogesterone. Then estrogel is a gel, which is estradiol hemihydrate. 2.5 grams is given daily, and dihydrogesterone can be added to it, or micronized progesterone, or LNG-IUD or MPA in the last 12 to 14 days if the uterus is intact. Even otherwise, estrogel can be used separately without progesterone if there is no uterus. What about HT for 45 to 60 years? The lowest for in these patients, lowest possible dose for the shortest period of time is given in order to achieve symptom management. Here we don't use 2 milligrams. Here we use much lesser dose. Treatment should be initiated before the age of 80, within 10 years of menopause, in order to maximize the benefits of HRT, such as improved bone health, while minimizing the risk of adverse events like CAD, stroke, VTE, dementia, and breast cancer. The decision to start treatment should be made on an individualized basis after discussion of risk, benefits, and symptom severity with patient. So what are the low dose preparations? We have Femistron 1 by 5, in which each tablet contains 1 milligram of hemihydrate estradiol and 5 milligrams of dihydrogesterone. It is given continuously only for short periods like 3 to 6 months. Then there is also Femistron 1 by 10. So what are the various routes of administration for estrogen? Well, they could be oral or non-oral. The non-oral administration is known to have no first pass effect on the liver, almost no effect on the BP, less risk of CVD. Thromboembolic events are lesser as compared to oral administration. So transdermal therapy is better in many ways, especially for patients who are at high risk of venous thromboembolism, who are smokers, who have high blood pressure, who are obese, and generally those patients who are intolerant of oral estrogen. They find it very nauseating. So suppose our patient Nandini says, oh, I don't want to have estrogen and progesterone. I've heard so much against them. So can we give her something else? Well, there are other therapies available. We have the SSRIs, the selective serotonin reuptake inhibitors. They act by increasing serotonin levels in the brain, thereby allaying anxiety and mental stress. So it all depends on what the problem the patient is facing. Suppose she has mental stress, they have to be looked into. You cannot say, "Theek ho jayenge," or it's part of the menopause. So we have ultimate aim is to make the person happy, and happiness is our ultimate aim. That is what I mean. So common SSRIs like fluoxetine, citalopram, sertraline can be prescribed in association or with the opinion of the psychiatrist. Tibolone, selective tissue estrogenic activity regulator. Tibolone is another very good drug. It is a steroid having weakly estrogenic, progesterogenic, and androgenic properties. It prevents osteoporosis, atrophic changes in the vagina, hot flashes, genitourinary syndrome of menopause, and the dose is 2.5 milligram per day. The advantage of Tibolone is that it reduces the risk of breast and endometrial cancers as compared to estrogens and progesterones, and the convenience of having just a single pill regimen is there. But however, there are not so many studies on Tibolone as there are on estrogen and progesterone therapy. Therefore, estrogen and progesterone still remain the priority. What are the other alternate therapies we have? There is gabapentin, which improves hot flashes and sleep quality. Acupuncture, acupressure, all these things help. Yoga, it reduces the physical, psychological symptoms of hot flashes, mood swings, depression, sarcopenia. It improves joint flexibility. Meditation. The whole world is taking up to meditation, and it's time we took it seriously also. Herbal remedies ashwagandha, shatavari, guduchi, brahmi, turmeric. We were just talking about turmeric. Then what about healthy diet? Phytoestrogens and avoid triggers like coffee, spicy food, alcohol. Then, of course, psychological counseling, homeopathy, naturopathy, music therapy, all these have important roles to play. In conclusion, the sequelae of gynecologic cancers and their treatments can include significant menopausal symptoms, which can be challenging for patients. Clinicians must therefore carefully assess the risks and benefits of hormone therapy in gynecologic cancers, survivors, and those with genetically increased risk of cancer. The important point to be taken as a home message is HRT is safe in patients with early stage endometrial cancer, epithelial ovarian cancer, and cervical cancer, according to the Society of Gynecologic Oncology and ACOG, using the lowest dose for the shortest duration. For patients for whom HRT presents an unacceptable risk, alternate treatments should be considered, including SSRIs, SNRIs, topical therapies, lifestyle modifications, but in general, HRT appears to be safe and underutilized for patients with early stage endometrial cancer, high-grade serous ovarian cancer, and cervical cancer. So, to end, let's promise ourselves that we'll always remember that we are braver than we believe, stronger than we seem, and smarter than we think. Thank you.